The new Cardiovascular Horizons conference took place in New Orleans on June 1st through June 4th, attracting interventional cardiologists, vascular physicians, surgeons, podiatrists, and other industry professionals from around the world. Known as the largest peripheral intervention conference in the United States, this four-day meeting unveiled new methods and data for the first time in this country.
All right, welcome to Your Health with Terrebonne General Medical Center. I'm Martin Folse. This gentleman really needs no introduction, but he is Dr. Craig Walker. Dr. Walker, welcome to the program.
Thank you, Martin.
Good to see you again. We talked about it the other night, but again, what is the new Cardiovascular Horizon, in your own words?
Yeah, New Cardiovascular Horizons is a conference which really covers all aspects of vascular disease, but with a predominant lean towards peripheral vascular disease. That's any disease outside of the heart involving the blood vessels. So this could be the blood vessels going to the brain, to the arms, to the legs, to the kidneys, to the gut, and certainly we touch on all of those blood vessels.
Who attends this conference? Go into detail on that a little bit.
Yeah, well, first off, it was a well-attended conference. We had physicians, nurses, podiatrists, but we had people from every continent, every inhabited continent.
That's
there
impressive.
were both presenters as well as attendees from every inhabited continent. It's many thousands of attendees, and it's really meant to push this whole field of understanding of peripheral vascular disease, both the arterial and the venous side of peripheral vascular disease.
Okay. The hosting of the conference, who's actually the host of the conference?
Well, I'm the chairman of the conference, and then the co-chairs of the conference were Dr. Cal Verena, Dr. Pat Lola, and Dr. Gus Ingraldi. They were the co-chairs of the conference. And then we had quite a few committee members that helped put it on.
Okay. Each conference is unique in its own way. What makes this one set apart, I guess, from the other conferences?
I think many things. One, there is the unveiling of new data, some of which was really the first time it was unveiled in the whole world. And so we had many coming to learn breaking results of studies. Secondly, as compared with other peripheral vascular conferences, and most conferences in general, there are a lot more live cases. In this conference this year, we had 25 live cases where the entire audience was able to watch on a screen 50 feet wide and see what we were doing, actually better than we can see ourselves in the cath lab. Given today's technology, this big screen doesn't lose anything in terms of resolution, and really very nicely see what one does.
Now, when we saw you at Terrebonne General Medical Center, you were performing a critical limb ischemia procedure. How did it go? What was the outcome? And it seemed like it went pretty well.
Yeah, it was very nice. It was a little lady. I did many cases that day, but this particular lady was a lady from North Carolina. She had actually had attempted intervention and surgery, 3 interventional attempts and 1 surgical attempt, all of which had failed. And she came to me because she was told that she only had as her option amputation, but her doctor suggested she come visit just in case there was something we might be able to do. And we were able to get the case actually pretty easily. We used a new technique that we've helped to develop called transcollateral crossing of a total occlusion. We came down through a little tiny branch and back up the main vessel, and were able to cross the total blockage and deal with it. And I'm happy to say that in just these few weeks since the conference, she has already healed her ulcer and has no more pain and is doing great.
She went from an option of amputation to doing well.
Yeah, and from being in excruciating pain that morning, to no pain at all post-procedure, which is a big deal, and it's not uncommon. Peripheral vascular disease, both arterial and venous, is a big thing. It's more common than heart disease, of course, because you have more arteries, and then of course you have the venous segment. And issues like venous varicosity, which cause people problems and don't look good, can become in their greatest state venous ulcers, severe venous insufficiency. And that really is a huge health problem. That's not just that it doesn't look good or feel good, that results in people actually getting in real trouble.
All right, we're going to take a break. We're going to hear from Terrebonne General Medical Center. When we come back, more with Dr. Craig Walker. Don't go away.
Put together a crew of top specialists, and you can do amazing things. Cardiac care at TGMC. It all begins here.
I'm a director here at the Little Theater in Houma. Sometimes I've acted, and I've even played in the orchestra. My name is Karen Chilling, and I was treated for breast cancer at Mary Bird Perkins at TGMC. Quality medical care and compassion should go hand in hand, and I definitely got that at Mary Bird Perkins Cancer Center. My doctors were incredible, and the technology is state-of-the-art. I believe that everyone at Mary Bird Perkins at TGMC deserves a standing ovation.
Welcome back. Dr. Craig Walker is with us today, and I know you do a lot of these seminars and all, but every time I go into CIS, you're seeing a ton of patients. How do you work all that in?
It's sometimes hard. I actually still see a lot of patients and enjoy that. It's really the reason I became a doctor and the reason I keep doing what I do. I like doing procedures. I like seeing patients. I like following patients and getting to know them. There are patients who I saw 28 years ago who I'm still seeing, and it's amazing. Some of these people 28 years ago came in hanging on by a thread and are thriving 28 years later, and that's a real sense of accomplishment when you see those people, you know, on a regular basis.
And you get to talk about new methods or new procedures that you introduce at the conference. What were some of those?
One of the things that we have done a lot of work with is the transcollateral crossing of total occlusions. See, typically one goes down with a wire and tries to cross long total occlusions. Well, a lot of times you cannot cross that occlusion in that manner. The long total blockage may be too hard. It may be that your wire wants to slip off into other vessels, and you just simply can't cross it. It's like trying to open a bolted door. If you can approach that same blockage from the other direction, often it's like just simply unbolting the door and opening it. It's much easier. So we have helped to develop some of the methodologies by which we can actually go around and come back up. That would be transcollateral, or transpedal, in which we actually stick foot vessels and come backwards.
So the manufacturers are really taking advice from you all on how to manufacture the items used.
They are. In fact, we basically as a group routinely, some of us meet with industry. We are flown up to meet with the big companies and to discuss what products we need or what products we may have an idea about developing, what things might help us better treat these patients.
We hear about PAD, but what exactly is it?
Yeah, peripheral arterial disease is one of the forms of peripheral vascular disease. The other form is peripheral venous disease. Peripheral arterial disease is anything that blocks arteries outside of the heart. So if this is the arteries going to the brain, some people would set that off as a different group, call that carotid vascular disease. Many would include it in the gamut of peripheral vascular disease, and I do. The arteries going out to the arms, the subclavian or brachiocephalic arteries, or the arms as they go out to the arms. These are very important because bypasses to the heart may come off beyond the origins of these vessels. So simply a blockage there may actually make one's heart starve. And it can also, of course, give you arm pain when you exercise, or it can cause what is called vertebral steal. You use your arm, and because it's having to suck blood out of the brain to keep the arm alive, you can pass out.
Wow.
Then as we go down, we have the gut vessels and the kidney arteries. If the kidney arteries become blocked, three things can happen. One thing is blood pressure may go up, and that's a common cause of high blood pressure. Secondly, your kidneys may not function as well, and it is a cause of kidney failure. And thirdly, it may put a strain on the heart, resulting in heart failure. With the gut vessels, if they become blocked, you hurt whenever you eat because you can't get enough blood to your gut. One of my heroes growing up was a man who played professional football from here. He had been a lineman. He had weighed 300 pounds most of his life. By the time I saw him, he had such problems eating, he'd gotten down to 120 pounds. This is a 6-foot man who played professional football. You can imagine that's quite emaciated. And then finally, and what most people think of as peripheral arterial disease, is anything going towards the legs. And that can be anything from the belly button down. And that results in diminished blood supply to the legs. In its earliest stages, that results in cramps in the muscles when you walk. And in the most advanced stages, it results in ulcers, in gangrene, and the need for amputation. And all of these are associated with a greater increased risk of heart attack. If we have someone with a diminished foot pulse, their chance of having a major cardiovascular event, a heart attack or stroke in 1 year is 20%. So you've identified by simply putting your finger on a foot pulse, a high-risk patient.
And that pulse should be the same as your upper pulse, right?
That's right.
Should match.
That's right. In fact, when we measure the pulse, we only measure the systolic, or the high number. So in actuality, it should be a higher number. And if I can tell you why, there was a very famous French man named Fournier. And what he did was he showed that over time in a tube, if you have a waveform, as you go further and further down the tube, the top is higher and the bottom is lower, much like breakers at a beach. The waves are rolling out at the sea. Then it comes into the beach and you have breakers. Well, most people think breakers have more energy, but by the laws of physics, they don't. If they had more energy, waves would be going from the beach out, not the other way. The difference is top part's higher, bottom part's lower. So in actuality, the pressure, if we're just measuring the top number in the feet, should be slightly higher than the arms.
I always knew you were a physics teacher, by the way. There you go. Critical limb ischemia. We hear you say it often, but what exactly is it?
Yeah, there are a lot of criteria that create critical limb ischemia, but in a nutshell, it's the following things. Critical limb ischemia is a term which was used to suggest that a group of patients in whom impending amputation was imminent if revascularization could not be performed. These people are the following: true rest pain. Now that's ischemic rest pain. Many people have neuropathy or nerve damage, which is different. But true rest pain, if a patient raises their leg, just the change in gravity's attraction for blood can give them pain. Or an ischemic ulcer, or clearly gangrene. Those would be respectively Rutherford 4, 5, and 6. Those all constitute what we call critical limb ischemia.
Okay. The symptoms of PAD and critical limb ischemia, are they similar? Are they different?
Well, critical limb ischemia, most people know they've got that. They look at their foot and they see an ulcer or a dead toe, or they're having pain all the time. But I've got to tell you, it's not as clear as that sounds. Believe it or not, there's some older people who can't raise their feet, can't see their ischemic toe. I had a patient come to me once and was talking about how they were having some discomfort. I took off the shoe, and they actually had a broken off toe. It was so mummified. It had broken off and they didn't even realize it was sticking out. So it's not that obvious. But if we look at just the earlier stages, believe it or not, only about 10% of people have typical symptoms. Many don't have typical symptoms. Many have what they think is arthritis, or they ascribe the discomfort that they have to being out of shape, or a million different things other than peripheral arterial disease.
So a checkup would find that pretty easily.
It would, and part of what we're trying to accomplish at our meeting is we're really trying to urge physicians to take people's shoes off and check foot pulses. It's an easy thing to do to identify a high-risk patient. A study was done once in which they looked at the utility of doing screening, ankle brachial index, which is measuring pressures in the feet, versus a mammogram. And if we looked at people who were over the age of 50 with diabetes or who had smoked, or anyone over the age of 70, regardless of risks, it was an infinitely more cost-effective screen than a screening mammogram. Yet it's not paid for routinely in America. We're hoping to get that changed because it's a big thing. If you're completely asymptomatic and you have an ankle brachial index of 0.8, which means the pressure in your legs is only 0.8 that in your arms, you're more likely to die in 5 years than a woman with a new diagnosis of breast cancer.
So 0.8 to 1. It's not much difference, but it is a lot of difference, isn't it?
It is in terms of prognostication. It is, because really it should be more than 1. And 0.9 is actually representative of disease. Okay. Just to give you an idea how common this problem is, there was a trial done in America, mostly in the northern part of the United States in the past. It was called the Partners Trial. In this trial, they looked at the ankle brachial indexes of any patient over the age of 70 or anyone over 50 who had either smoked or had diabetes. What they found was 29% of those people, which represent a huge percentage of our population, had peripheral arterial disease. Now understand, many people much younger than that have advanced peripheral arterial disease. I've seen people in their 20s with gangrenous changes of toes. Also understand that you may have advanced disease and have a normal ankle brachial index. If the arteries are so calcified that the sphygmomanometer cuff cannot squeeze the artery shut, it may look like you've got a very high pressure in your legs, yet you have very advanced blockage. So it's also important to couple that with the appropriate history and physical exam.
How can people get more information? I know you're out front and you like to give it, but how else can they get it?
Well, certainly there's a lot of information on the internet. We have a website with new Cardiovascular Horizons in which people can actually even see cases. Certainly at our office we have a ton of pamphlets and other information about peripheral arterial disease. And really this has been one of my life crusades, to be honest with you. And I think it's been one of the things that has helped us really dramatically drop death rates in our area. When I moved back to this area, we had one of the highest death rates of any Medicare catchment region in the United States, one of the very, very highest. Now we're amongst the very lowest. And clearly, in that time frame, it's been the greatest change from bad to good. And I think a big part of that has been our aggressive stance on evaluating peripheral arterial disease. Many of these people simply are not being evaluated and therefore don't have their heart or carotid arteries evaluated, which is typically what kills them.
You're going to teach in New York, I hear?
Yeah. I've got a conference there, then I have one in Chicago, but a lot of things going on. A lot of my weekends are taken up with giving talks, of course. In fact, last year, I hate to admit this as a true Cajun, but I didn't go fishing one time, which is heresy for me. I'm a big fisherman, that's right. That's a hard thing for me not to do, but it's been taking up a lot of my time. But it is really one of my missions in life, is to improve the understanding of peripheral arterial disease and hopefully improve the treatment of this.
Well, thank you for what you do, and thank you for joining us today.
Thank you, Martin.
All right, once again, we'll take a break. When we come back, Nicholls State University on the set. Don't go away. It's all next.